definitely you are going to prevent, and you don't have to give excessive other additional uterotonics. Otherwise, you have to give a IV isotonic any solution, then you add oxytocin to that, then you give prostaglandins and all those things. That can be definitely a lesser.
And finally, madam, what's your take-home message for the doctors who are attending?
See, when I said that preventing the preventable is our duty.
Yes.
Okay.
It's well
And
said, madam. Yes.
why should a woman die due to postpartum hemorrhage?
Correct.
She shouldn't die. Okay. Yes, I won't say that PPH cannot occur. PPH does will occur.
Yeah, yeah,
I'm
yeah.
not saying that. But you have to be prepared, you have to be ready. So you have assessed all the factors antenatally, corrected her anemia. You know where to operate if she is a high risk patient, we should take her.
Correct.
Okay.
Correct.
And by giving carbetocin, we are reducing the blood loss. Definitely. Today only we delivered one patient with twin pregnancy.
Oh,
Okay. So I told them, you be ready with carbetocin. She is going to bleed more. We know. So we were ready with suction cannula, everything, IV line, proper IV line, and everything, right? So all those precautions we have to take.
yeah.
So I think that's what I would say, that if I
Yes.
know that if government gets it at a reasonable rate, and government will
Yeah, correct, correct,
always,
correct.
the cost comparison is happening with
Yeah.
carbetocin and oxytocin. So if that is improved,
Correct.
and if the private companies start giving it at a very reasonable rate, definitely
Absolutely correct.
government will come forward and will be able to save the mother.
Absolutely correct. Madam, now coming to your slides.
So I told you about emotive. So now when we have to escalate, we will need a mechanical methods and new gadgets. Okay. So next slide. And sometimes, in my now 42 years of experience, I have seen these type of blood loss. Okay. And we are closely related. Next slide, please. You can go on, change. And hemorrhage in pregnancy is different from other hemorrhages. Next. Next. So there was a patient who delivered, okay, and she was fine. But next few minutes, the nurse noticed a sudden gush of bleeding. Yes, uterotonics were given, massage started, bimanual compression done, and still the uterus remained flabby. And IV line in situ was started, but she had it as she came in active labor. Next. Now, as I told you, estimation of blood loss is very important. So how do you quantify now? So nowadays we talk about quantifying the blood loss. Yes. So quantification is you have to weigh the blood soaked pads, linen and gown. Now, if you have to weigh them, then you should know the dry weight of them. Direct measurement, that is the collected blood in graduated measurement containers, or if you have the drape, which delivery drape, which you have kept under the patient, then you find that there is a drape and blood is getting collected there, so we can measure that. Now, so the weight plus measurement, that is whatever there, or you have kept a mug in the bucket if there is a Kelly's pad. Yes, you will have to minus the amniotic fluid. That will be the total blood loss. Next. Next. So she had noted that the collection in the drip was 100 ml before delivery. So that you will have to minus. After delivery, the total volume in the drip was 700. The dry weight of 5 mops was 100 grams and 10 mops were used. And the final weight of the mop was 575 grams. Next. So you can do this. Weight of the wet mops 575, dry weight was 200. So minus, if you do 375, and 700 ml minus 100 ml. Okay. So that will be 600. So how much is the total blood loss? 375 plus 600 will come to 975. So that means this patient has almost lost 1000 ml. Next. So what was done in this patient? We started the IV line, we added oxytocin, and then in spite of that also the patient expelled a large clot. And suddenly we found that her blood pressure dropped to 80, pulse rate 120. So we calculate the shock index. Now what is shock index? Shock index is pulse rate divided by systolic blood pressure. Now normal patient, it is 0.7 to 0.9, okay, in pregnancy. If it goes beyond 1, that means your patient is in shock. Now here it is 1.5. That means she has already lost more than 1500 to 2000 ml blood. Now immediately we started giving other oxytocics like Carbopros 250 microgram was given immediately. So, and how that shock index is useful. Next. So as I already told you what is shock index, okay? And you will have to act accordingly if the shock index is increased. So if it goes below zero point 0.9, you have to be alert. You have to start two large bore IV cannulas, give her fluid, isotonic, ringer lactate or normal saline and run it fast. Okay. So because you must have collected the blood, you will send it for grouping cross matching. But till the blood arrives, if there is a shock index, you know your patient is hemodynamically unstable, you will have to correct it by giving IV fluids. Next. So this I think we already discussed about the stages of hemorrhage. So stage 1 is compensatory, but stage 2 should not lead to stage 3 and stage 3 to stage 4. So what is our duty is we'll have to act fast and see that we prevent the blood loss. Next. So this is the golden hour. You have diagnosed the postpartum hemorrhage. So you call for help. I will say you shout for help. You have to assess the A, B, C, D. That means what? Airway, breathing, cardia, okay, and patient's response. Two wide bore cannulas, number 16. Collect the blood for investigations, cross matching. Catheterize the bladder. Distended bladder will cause atony. Palpate the uterus. Start massaging. You will have to explore whether there are any tears. We talked about uterotonics, and then you will have to use some mechanical methods like a balloon or a suction cannula. And if the patient continues to bleed, you will not wait because you will need more help. You may plan to shift her to ICU or HDU if you find that the patient is deteriorating or bleeding is not getting controlled. And you will also take the consent of the relatives and do the counseling. Next. So this is a simple PPH box which we started using in Bangalore Society of Obstetrics and Gynecology. And even in a smaller hospital, no, you don't have a crash cart, but we can keep everything. So you have to be prepared. What does it contains? It contains A, B, C compartment. A is for airway. So you have an airway because if your patient is collapsed, there should not be tongue fall. And oxygen mask. B is blood, related to blood. So all those vacuum containers, the blue color, red color, and purple color to collect the blood, syringes, then the tape to draw the blood, all those, even a swab, even a sticking plaster, everything is kept there. And C is catheter. So you have a Foley's catheter, whatever is required for the Foley's catheter. And we also keep some condoms there so that if you have to make a balloon in the labor room, we don't have a Bakri balloon, ready-made balloon. We can make a balloon out of these condoms and we can use it as a condom tamponade. Next. So tranexamic acid, I have already discussed with you. There is no need to wait. Emotive, I told you have to give tranexamic acid. Next slide, 1 gram in 100 ml of normal saline. Next. So, tranexamic acid, how it helps? It has enhanced fibrinolytic activity, and fibrinogen depletions are common in early stages. So, you can give 1 gram over 20 to 20 minutes, but you should not delay it. You have to give it early, within 3 hours. Because if bleeding persists after 30 minutes, we can give a second dose of 1 gram again, and it has an antifibrinolytic effect, which will last up to 7 to 8 hours. Because delaying treatment, even if short, it reduces the benefits of tranexamic acid. Next. And this was from 2017. There was a women trial, and we started using this, and it did not increase the risk of thromboembolic events practically. So even though theory they mention, yes, we do give when there is a postpartum hemorrhage, whether delivery, vaginal delivery, or a cesarean section. Next. Next. So there is a recommendation by all, and this is study where they say that definitely the blood loss reduced when they're given it prophylactically, but still there is no WHO guideline. But there are some studies that when it is used before putting the incision on the uterus in a cesarean section, it can help to reduce the blood loss. Next. Now the anti-shock garment, next slide please, is one of the garment which has 6 components, and it is applied on the below the abdomen till the lower limbs. It controls the bleeding through direct pressure. There is auto transfusion of blood in upward direction, and there is a ball in the abdominal segment which applies focus pressure on the uterus. And that pressure on the lower half of the body reduces the total vascular space. Vital organs get increased blood supply and oxygenation like heart and brain, and it stabilizes the patient during transport. Next slide, please. As well as when we are planning to do some surgery or something. So every labor room, when we say readiness, this anti-shock garment must be available. And this anti-shock garment has 6 segments. You can see the lower one ankle, second calf, third thighs, fourth is on the pelvis, fifth is with the ball, and sixth is to cover that. Okay. And it can be even left in place for 16 to 36 hours where you are trying to correct a hypovolemia, giving blood, you can keep it. Next. So uterine tamponade also, I said, when you escalate, you think of that. Will it help and how would you use it? Next. So there are different types of balloon. Now the Bakri balloon is available, and Rush balloon is available. Or we have a simple condom catheter which you can see, you have a condom, you just put it on a catheter or a suction tube, and you tie it up, and then you insert it into the uterine cavity and connect it to an IV bottle. It starts filling up, and it will fill up the whole uterine cavity, and it will control the bleeding. So this is called as tamponade. You can see one more balloon which has 2 balloons. That is, one is for the vagina. Next. And it should be placed properly, because if it is improperly placed, what will happen? The most of the part of the uterus will not be compressed and the patient will continue to bleed. So proper placement is very, very important. Next. And if you don't have a condom, you can also use a glove. Okay, even a glove can be used. Now, what the study says, in uterine atony, it is almost success in 87%, vaginal delivery is 87%, placenta previa also 86%, because it will compress the lower segment also. In cesarean also the same. And in placenta accreta spectrum also, if we are doing a conservative study, management, where we have not removed the whole placenta, even there also we can use it. Next. Now, the another method of tamponade is a suction cannula, which we are using in fact, today I used it, I told you, for the twin pregnancy. Next. So this is the cannula with a negative pressure is applied, and inside the uterine cavity it is created. And when it is introduced, it is connected to a suction apparatus, and a negative pressure of 700 millimeters of mercury produced. And this results in aspiration of the all collected blood, and it will not allow anything to get collected, and the uterus will contract and retract like this. So when the collected blood is completely sucked out, the bleeding ceases. The suction is maintained for 30 minutes or 15 minutes will also do. And then you switch off the suction, then the cannula is taken out slowly after releasing the suction. So, and if you find that there is still bleeding, then we may have to again put it inside, or sometimes we leave it there and we wait for some time to see that if she develops atony again, then again we switch on the suction. Next. So there are different, that was the Panikar cannula. This is the SR cannula, Samartharam cannula. You get different sizes for delivery as well as for suction. For cesarean, what we get is slightly shorter than the one which we use for the vaginal delivery. They are available, and you can go on Amazon and search, and they're really, really helpful. It really helps to control postpartum hemorrhage. Next. Now, Carbetocin, I won't go in detail. I think you can go ahead. Carbetocin, I don't have to talk about it. Go ahead, go ahead. Then go ahead. Next. Next. Now go to previous slide. Yeah. So the blood and blood products were arranged for this patient. Condom catheter was inserted, which was removed after 18 hours. Anti-shock garment was applied. and patient was monitored for 24 hours and she stabilized gradually. So early preparedness and prompt treatment will definitely help to control postpartum hemorrhage. Next. So the learning points, we have newer drugs like tranexamic, we have carbetocin, okay, and older but less utilized methods, we can still use balloon tamponade and suction cannula and NSG, which can save lives while all these are being implemented. Next. So is there any novel method? Next. I told you about this, that EBS catheter, which is available in India now, but most of the time, whatever is available, we can use that, okay. 750 ml for the uterine balloon and 300 ml for the vaginal balloon. Next. And the pelvic pressure pack for persistent pelvic hemorrhage. So when we are talking about tamponade, suppose we have done the hysterectomy and the patient is bleeding because she is in DIC. So what we can do like this umbrella type of a pelvic pressure pack, because it's very difficult. You don't know from where she is bleeding, how to catch the bleeder, and you can apply weight also. And later on, we can remove this pack from below. Okay, next. Any newer instruments? Now we have newer instruments, next slide, to tackle this bleeding vaginally. Like there are clamps, we have the clamp which can be applied by the side, that is at 3 o'clock and 9 o'clock position. Okay, next slide. There are different modifications which are done by Dr. Piley now. This diagram is showing the older one. The newer one has come where we can go straight up to the posterior fornix up and we can clamp. Don't worry about the ureter. As you are pulling the cervix down, the ureter will fall away because ureter is not there in the fascia. It is away. So don't worry about that. And this clamp also can be left in situ for 3 to 4 hours. You are clamping the uterine from below. Next. This is again Dr. Ram Lingappa from Hubli, who also have these paracervical clamps. Even this can be also used to apply. Next. Now this is the PPH tray. This is for the traumatic PPH. So you must have this type of tray ready in your labor room. You should not be just searching for 2-3 speculums. You have a deep speculum, which is posterior wall. It will retract, a big sim speculum, and you should must have 3 or 4 sponge holding forceps, a ribbon gauze if you need to pack, Alice, scissors, sterile pads, suture materials, and even condoms, because you can also use this condom tamponade for the vagina. Next. So remember that active management of third stage of labor will act only for atony, not for traumatic. You have to give uterotonication, and then tonacious bleeding is occurring. Even if uterus is contracted, give tranexamic. And traumatic may be associated with atonic, or atonic may be associated with traumatic. So we should anticipate, prevent, diagnose, and treat early. That we have to remember. Now, if we have for example, the cases of placenta accreta syndrome, then the planning is very important. So, or a placenta previa, you have to take informed consent. Even for hysterectomy, you need a multidisciplinary team because the placenta is adherent to the bladder. You may require a urologist, a oncosurgeon, a vascular surgeon. So, no case of placenta previa or placenta accreta syndrome should be managed without the multidisciplinary team. A proper IV access, blood bank facility, very important. You will need Foley's, and sometimes some people prefer to put even the ureteric stents, and then drugs, anesthesia, post-op care, endovascular intervention for hemorrhage control like uterine artery embolization and thromboembolism prophylaxis is also required. And you have to decide where to put the uterine incision. So if you have ultrasound, then you know it is a low-lying placenta. Next slide, please. Your incision should be always above the levels of placenta. So that means you are not going through the placenta, because if you cut through the placenta, there will be torrential bleeding. And you have to plan whether you are going in for radical, that is if you are going for hysterectomy, then you do a classical cesarean section. You extract the baby, don't touch the placenta, don't give oxytocin, straight away apply the tourniquet to the lower segment and proceed with hysterectomy. Okay. So if you are using a conservative method, then there are different methods. Yes, you will have to use a uterine compression suture like B-Lynch or a uh, stepwise devascularization, internal iliac artery ligation, then utero-ovarian vessel ligation, and triple P procedure. Now, triple P procedure is a conservative method. Hello, doctor, I am in a webinar. I'll call you in 10 minutes. And then triple P procedure is like you have to first know where is the placenta. You have already taken the help of interventional radiologists where you do uterine artery embolization, and that will help to reduce the blood loss. You can use a tourniquet, and some part of the placenta is left behind. We can just, instead of going on poking, just remove that much part of the myometrium from the lower flap and then suture the upper to lower. So what happens, this uh, part of the myometrium with the placenta is not left in situ, because that will keep on bleeding otherwise, and suture. Yes, tourniquet definitely. And sandwich technique is sometimes used where you do the compression suture. Along with that, you also insert a balloon inside the uterine cavity. Next. So these are the different, and dear friends, if you want to watch these procedures, you can access my YouTube channel, that is Surgical Management of PPH by Dr. Sheela Mane. You will find it on YouTube, and where you will get a demo of all these procedures on a model. So you have a Cho suture and all those. And then Periara stitch is transverse as well as vertical. Now Heyman suture is the easiest, where you just go vertically on both the side and ligate it so that you are compressing the cavity. And there is also a transverse compression suture for the lower segment, which we call it as cervicoischemic, which you are seeing there with the Heyman suture down. So that will help for the lower segment bleeding. So you can take through and through and compress the lower segment. And we know that all these compression sutures were introduced none other than first the legend Professor Lynch, and I had an opportunity to do so many workshops with him. And the uterus model which I have is been his idea only. The Cho suture is again taken at multiple sites, where you know that multiple sites are bleeding, where you go through and you try to approximate the uterine wall. But for this, as you are going through and through, you will need a 10 centimeter needle, a long needle, because you'll have to go from anterior to posterior and again come back. Next. Next slide, please. Uterine artery ligation, O'Leary stitch was the technique, and it has become most popular, and it has a success rate of almost 80 to 90, because uterine artery is the main blood supply to the uterus. Okay, it comes from the internal iliac artery. The another blood supply is where there is a utero-ovarian anastomosis, that is up near the cornu. Okay, and the complication is very rare, so sometimes we do both. We do compression as well as uterine artery ligation. Okay, so it is indicated in atonic rather than sometimes in traumatic also. Suppose if there is an extension, we are doing a cesarean section, we find that the angle is extended. Yes, we can do. We may have to do the uterine artery ligation. Okay, and we also have to ligate the descending artery in cases of placenta previa, because that is the artery which is supplying to the lower segment. Then coming to the stepwise, that was by Abrabo. In stepwise, what? Step 1 and step 2 I told you. That is, you are doing both ascending and descending of uterine. Then step 3 is you are ligating the utero-ovarian anastomosis, because there is a branch which anastomosis there, and it has almost a success rate of 94 point. So what you may think that what happens to the blood supply, but the collateral circulation develops and everything falls in place. Next. Okay, so these are the uterovarian vessel clamps. Suppose if you want to control the bleeding during surgery, you are proceeding for hysterectomy. So the technique which is used is clamp, cut and drop. Like we don't go on suturing, we just clamp, cut and drop, because you have to finish the hysterectomy quickly. Next. Internal iliac artery ligation. It can be effective to reduce bleeding from all sources within the genital tract, even traumatic also. It reduces the pulse pressure in the pelvic arterial circulation, and the pulse pressure was reduced by 77% with unilateral ligation and 85% with bilateral. So even mostly we do bilateral only, and it has a variable success rates ranging from 40 to 100%. But at that moment when you have to control the bleeding, it is a life-saving procedure. For tourniquet, just you can take a simple Foley's catheter and you can use it. Next. Sandwich procedure, as I told you, that along with the compression suture, you can use a balloon inside. You have to just inflate it up to 100 ml and then push it through the os below. close the uterus, and then later on, if you find still there is a bleeding, you can inflate some more till the bleeding stops. Now, this is the aortic compression. All of us must remember that our idea is to control the bleeding to control. So if your patient continues to bleed, you're doing something, you can ask your assistant to do the aortic compression. Okay. Recently, we saw a picture in ACOG. Somebody has used even the knee pressure. So you have to go above the umbilicus towards left side and compress the aorta. And then with the right hand, you can feel for the femoral pulse. Of course, that should not be felt. And what happens? That controls the bleeding. That is if it is a vaginal. If it is a cesarean, easy, take a wet mop and ask your assistant to be on the left side at L3, L4 level and compress the aorta. Now, Dr. Paile has also come out with an aortic clamp, which can be also used particularly in cases of placenta accreta. Okay. It can be left for 30 to 40 minutes. Yes. Uterine artery embolization. Next slide. We do that as prophylactically. We already put the catheters in situ. And after the delivery, if we find there is a bleeding, we just pass the embolus and try to block the arteries, and that also helps. And the overall success rate is almost 90% with a complication rate of 4.5%. So there are prerequisites for the uterine artery embolization. Next. Yeah, you need a personnel and the facility readiness. Women with persistent slow but excessive bleeding it can be done. They have to be hemodynamically stable. Okay. And hybrid theater, it should be there by the side only, C-arm and everything. And diagnostic angiography is initially performed. You can see on the screen which vessel is bleeding. And then you can also look for, any extravasation, any AV malformation, pseudoaneurysm, spasm, or truncation. What is used to block is gel foam or N-butyl cyanoacrylate. Anyway, that is the decision of the radiologist, interventional radiologist. Next. So, dear friends, obstetric hemorrhage is always very furious, next, and fast and frightening. So, all of us have to be prepared always for every case. So, if there is a lack of preparedness, inadequate action, lack of poor communication, improper documentation can lead to medical legal issues. So, we have to be always prepared. So, the summary is sequence of non-operative and operative interventions for control of PPS should be documented. Promptly assess the success or failure of each measure. If an intervention does not succeed, the next in the sequence must be swiftly instituted because indecisiveness delays therapy results in excessive hemorrhage. And there should not be the lethal combination of DIC, severe hypovolemia, tissue hypoxia, hypothermia, and acidosis because then the shock becomes irreversible. And if there is a DIC, we have to give a massive transfusion. What is massive transfusion? You have to tell the blood bank to first send you 4 PRBCs, 4 FFPs, and 4 platelet. Okay? And if that is also not suffice, you will ask for again 444. And nowadays, if patient continues to bleed, okay, you will have to ask even for cryo. Because cryo contains more fibrinogen. Your patient is losing blood. She will have less fibrinogen. The blood will not clot. So ask for cryo. So all these cases to be managed, you need a backup of a robust blood bank. Now other drugs are also available, like you have an injection fibrinogen, you have factor 7 also. Now even injection fibrinogen can be given. If you have time, you do not have the blood bank, you can keep these vials ready and immediately give. Now, to know whether there is a fibrinogen deficiency, you do a point of care test. What is point of care test? Draw 5 ml of blood in a test tube and go on watching it. Now, the normal blood will clot by 7 minutes or 9 minutes. If it is still not clotted, that means the fibrinogen is less and we can gear up to give the blood and blood products because the laboratory report will take at least 30 to 45 minutes to know whether the coagulation is altered. So Do not allow your patient to go there. You have to order the blood and blood products. Immediately give PRBCs, because PRBCs will help to increase oxygen saturation. Patient otherwise go into hypoxia and acidosis. Then you give FFPs and platelet. FFP again you may have to thaw. If patient requires more blood, you ask for cryo, because cryo contains fibrinogen. Okay, and other factors also, factor 7 and factor 8 and all those things. So now this will make control of hemorrhage much more difficult, and it will increase the likelihood of hysterectomy. And even if you do, when the patient has gone in for DIC with all these complications, the chances of survival will reduce, and there will be a morbidity also and mortality also. So one should not land up there. Today's scenario, all of us, patients are clever, they know everything, they can find out, they will try to find out, even if everything has gone right, they will try to find out whether we have done something wrong. So we have to be very careful when we are dealing with the mother, and it is a question of two lives. Thank you very much for your patient hearing.
Thank you so much, madam.
Yeah.
It was lovely listening to this session on PPF. I mean, we did not know, honestly, I did not know so many techniques that are happening today. And it's lovely to know all this. I mean, the science has gone way ahead, but God bless, no one should get these cases. Thank you so much. I'm sure the audience has benefited out of both the medical part and the surgical part of managing PPH, because we really do not know when the patient will go and need a surgical management. Thanks for enlightening all this. Thanks, madam. Bivas, you want to add something?
Yeah, thank you, ma'am. Thank you so much for accepting our invitation, ma'am, and for such a wonderful session, ma'am.
Thank you. Have a
Thanks, madam. Thank you so much. Wish you
So,
very
ma'am,
good
we'll be
evening.
meeting again on 23rd, Monday, and
okay.
same time.
Fine. Okay. Done.
Right, ma'am. Thank you so much, ma'am. Thanks a lot.
Thanks, Bhuvan. Thanks, Bivas. Thanks,
Thank you,
Tanvi.
sir. Thank you.